Thank you for all our speakers for excellent presentation. Maybe we'll have one or two questions because of the time.
Professor Ernest with us.
Okay.
If there is a question for Professor Ernest.
So, Professor Ernest with us. Any question for Professor Ernest? Yeah.
Assalamu alaikum. Thank you so much, Dr. Ethan, about the informative presentation. So just I have two questions for you, if you don't mind. The first one, do we have any new idea about the anti-complement medication like xylocoplin to treat the patient who have necrotizing myositis? And the second question, you mentioned about the role of tofacitinib in treat the patient dermatomyositis with cutaneous disease. So my question is, can we use it as a first line, or we have to use it, as you said, fourth line after the multiple line failure of management? Thank you.
Sorry, I didn't hear the first question well. You said what was the medication?
Anti-complement medication. They call it
Aculizumab, you mean?
Yeah, xylocoplin.
Okay.
There is a study talking about to use, it was a new study talk about this medication last year. So I have no idea about the update because it was a big project about this medication. By the way, it has been used in patients who have myasthenia gravis. That's why I would like to ask you about this question.
So I'm not sure, I couldn't find or I did not come across any literature about complement-based treatments for myositis, but they were quite, or other pathways targeted like CD52 and others, but the problem with that was targeting these lymphocytes resulted in improvement in the muscle, but progression of the lung disease. So I'm not sure if complement-based pathway therapies would result in anything different or similar. I'm not sure. I did not come across it. Now, tofacitinib, as you can see, what we have got so far are case series and reports, and it seems to be doing good on multiple aspects of dermatomyositis. The only problem with case series and reports is you don't get the negative reports. You don't get the cases that don't respond. You get the cases that do respond. So we don't know if we should use it first line or second line, but certainly if you have a patient who is not responding, or you have a patient with extensive calcinosis that you know this patient will definitely not respond. You know calcinosis does not respond to the usual therapy. In that case, I would use tofacitinib first. Or if you have fulminant pneumonitis, you know that the patient is going to lose his lungs and probably his life very quick, I would use either combination or tofacitinib. But in the usual myositis, I would go first line first and then tofacitinib later.
The last question for you, Dr. Faddal. Regarding the combination therapy in treating of the anti-MDA5, do we have any idea about the risk of the infection?
Oh yes, basically this was compared to the usual step-up immune suppression. So when they did the comparison, the risk of bacterial infection was comparable, but the risk of CMV was higher in early combination. And the reason is, if you look at in this population, they won't respond to only cyclophosphamide. So with time, they accumulate more immune suppression, and that eventually results in a similar or comparable risk of infections. So the risk of infections was comparable, but keep in mind, it's a very small number, so they were only around 20s, and they did use, I would say, very quick CMV therapy and PCP prophylaxis from the baseline. So with these considerations, it seems otherwise, they did comparably well.
Thank you, Dr.
Thank you very much.
Dr. Ibrahim?
Thank you. I have a quick question, Professor Ernest. I'm not sure if he's with us or not. Is he with us?
Is Dr. Is the professor?
Yeah,
with us?
hi. Thank you for a wonderful talk as usual. So you did highlight or you focused on the early clinical presentation of arthritis. And the question is, in those people with early RA, probably you have some data, as you showed, data to support the aggressive approach in terms of achieving remission and the impact on drug-free remission. The question that we are facing now with the earlier presentation and those with undifferentiated connective tissue disease presentation, or those who fit early arthritis with no major risk factors, i.e. those with inflammatory arthralgia, arthritis, but no highly positive antibodies. And we know when we follow those people up over time, majority of them evolve into an RA presentation. So perhaps that indicate an earlier preclinical or early clinical presentation. So in this population particularly, do you think that there is room for aggressive therapy? Since we know the data on methotrexate, for example, in this population, at the end, the outcome seems to be the same. So what about the newer agents? Do you think that that will do better?
Oh, actually, I think there are several trials in this population in progress, and we're expecting results quite soon. I think all the study are now focusing in that population, patients who are ACPA positive, because it's clear that if you are seronegative with those symptoms, you're less likely to progress to persistent arthritis.
Okay, fair enough. Thank you.
Last question by Dr. Muhammad.
Thank you all. I just want to ask Dr. Hanan to comment on the issue of recruiting patients in the registry. And worldwide, many registries have been developed, and not every person who puts patient in is a co-author. And this is well known to all academic centers. And some registries have been built on compensating rheumatologists on their time in introducing patients. So when we say that every colleague who's going to introduce or register 50 patients is going to be co-author, once you have a registry of 1,500 and you have 30 rheumatologists, you cannot put all of them as a co-author. So I would like to have your comments on that. There should be a better way to offer or give authorship to colleagues, because even if there is no tangible direct benefit for a rheumatologist to put his patients, this is a national project that will help the country, and we should all adhere to it.
Yeah, thank you, Mohammed. Actually, we discussed this issue several times, but because rheumatoid arthritis is a common one, so we expected that each rheumatologist he is having minimum of 100 patients. So to register 50 is not much. But again, we can discuss it. It's just not just and we can reduce the number if we have if the other center, especially the new colleagues, but he's active and he's covering all the idea is not just put the first visit. He should longitudinal cohort, so they should do all the visit every 6 months and complete. So for those who are very active and completed, and he have an idea about research and maybe so there is a research committee we can cover. So it's not. 50 by 50, but we choose 50 for rheumatoid arthritis because it's common, and we are planning maybe in the SPA and the other like 20 cases maybe enough for spondyloarthritis to start with. Okay.
So
Hanan, can I contribute here just to help you in the discussion about authorship? One way around this, from each center you should have to select one PI and the rest of the authors in behalf of the group, so you can list the author at the end of the paper as a long group. It could be 50, 60 authors, it doesn't matter. But the PI goes in the beginning and the rest of the author goes at the end of the paper. Most journals accept that.
Yeah, this is a very good option, yeah. Thank you.
thank you.
Thank you, Professor.
We reached to end of our session. Thank you all. Thank you, our speaker.